Well, thanks very much, Susie. We finally welcome Mr. Andrew Sinclair from Stepping Hill, Stockport, to update on andrology. Andrew.
Thank you very much. Now the first thing to say is that I've managed to use all of my 3-year study leave in 2 years, so I've had to rely on lots of people in my section to give me advice on what to talk about from previous meetings over this year. So there's lots of people to thank as I go along. We're going to cover these topics quite quickly, so I won't go through these now. First of all, I need to thank Sux for helping me with the male infertility side of things. Obviously, most of this is very highbrow. I don't understand much of it. So I've focused on the things that I do know about and which would be relevant to the core urologist. So we're still talking about varicoceles. Now, I think the debate's been going on for many years, but I think we all agree now that in young men with testicular atrophy or in men with a clinically palpable varicocele with abnormal semen parameters and male factor infertility, we do go ahead and treat the varicocele. The debate is now going to head towards which way we do it. So there's lots of papers coming through on microsurgical techniques versus embolization. And there was a cost-effective analysis this year that showed that actually in the States it's more cost-effective to do the procedure with microsurgical techniques. I think the battleground is still that middle box at the bottom in the patient who's got male factor infertility with a varicocele but no abnormal parameters. And this paper started to look at DNA fragmentation or DNA damage, and there's some evidence that you've got higher risk of DNA damage in people with varicoceles, and that by treating the varicocele the DNA damage rate goes down and then the pregnancy rates go up. So that's an area to watch this space. I need to thank Roland Rees really for helping me with this side of things. This study was published a couple of years ago, the IMPRESS study, and I think the reason this is relevant to everybody in the room is that we're all desperate for some treatment other than surgery that will work for Peyronie's disease. Now, there is good evidence that this works, and you can improve the curvature, so there's a 38% improvement, which sounds very good. Asif Munir spoke to me about the role that actually in this study, the people that did better are the ones that actually had the less curvature to start with. So if your curvature is less than 45 degrees, then you're more likely to get benefit. So this all sounds very, very good, doesn't it? We're all going to be using this as of next week. Well, unfortunately not, because although it's now got the European license, NICE have not yet offered guidance on this. I think the biggest stumbling block is going to be not only the cost, but also the time commitment. So it relies on 2 injections, 1 to 3 days apart, and then a further visit, another 1 to 3 days apart, so that you can do modelling before the patient then goes on to try and model. So you've got 3 clinic visits in the space of 9 days. My waiting list for my next follow-up appointment is 9 months, so I don't think I'm going to be squeezing them in that tight. You've then got the problem with costs. It's £700 per vial, so it's actually £5,600 just for the collagenase treatment. That doesn't include any other costs. On Monday, I asked the question at our meeting as to whether anybody in the room was doing this on the NHS, and the answer is currently no. So this is a very expensive treatment that's only available privately at the moment in selected centres. Moving on to male slings and artificial urinary sphincters, there are lots of male slings. That normally means if there's lots of something, it means there's not really one good one. We are all in the UK mainly using the advanced male sling. I think a couple of people are starting to use the coloplast. The gold standard is the artificial urinary sphincter, and there's a very good reason for that. It's an excellent treatment with good long-term data over 30 years. So why do people want to choose the sling? Well, it's for the people that don't want the invasiveness of the artificial sphincter, often people with the milder incontinence. NICE guidance currently recommend that the only thing we should be using is the artificial urinary sphincter, and that slings and injectables should only be used as part of randomised controlled trials. And this is where the master trial trial comes in, so I'm using my plug as we go through. The master trial is for any man with male incontinence, and we're trying to randomise them to either a sling or a sphincter. The problem with that at the moment is that we're just tailing off on the recruitment, and quite often we're finding that the reason for that is that the patient's already been told by somebody exactly what they need before they see us. So often the referral letter comes through saying, please can you put a sling into this patient, or please can you put a sphincter into this patient. We'd appreciate it if people could be referred with their incontinence so that we can have a discussion about the trials and the relevant options. Paul Anderson gave a talk on Monday. He's managed to go to every single meeting this year, and he started by saying there's not that many updates or brand new things in reconstruction. I think the reason for that is that we've already got a pretty good set of operations, so the aim of most reconstructive procedures now is to keep the outcomes but minimise the morbidity. So at the moment we're in the process of doing things with less invasiveness, preserving more of the vascular supply so you get less of the erectile dysfunction or gland flaccidity. Steve Payne helped me with the urethroplasty data set. He's been working for 6 years, making sure we all collect our data. Moving over to the dendrite system has been very beneficial to us, and it's a lot easier to collect our data. So far over the last 6 years, we've accumulated over 4,000 new patient episodes with 2,300 follow-ups. Steve's going to be publishing this data later on this year, but the main reason we put it into the room is that this is what we're going to use for our outcome measures, and this is due to be in the public domain in November later on this year. We already have a validated PROM which we're going to start using, and it's going to be a part of the basic criteria, and we're going to use a modified IIEF score to help with this data set. The second plug is for the open trial. Thanks to Rob Pickard's dedication to this trial, we are keeping going, and it looks like we are going to meet our recruitment targets by the end of this year. This is really a plug for anybody who's got a recurrent bulbar stricture. Please can you refer to one of these sites for consideration of the open trial. It'd be great if we could meet the recruitment date by the end of the year. You can see there we're actually just above it, but we do need to carry on. Rob really has had to bully and push us into making sure we do this properly. The last few slides are on erectile dysfunction. Finally, sildenafil or generic sildenafil is off the schedule, so we can be prescribed to anybody on the NHS. We're moving, towards LUTS and ED. Lots of the commissioning side of things, this is quite difficult because it becomes expensive, but there is a common link between the etiologies behind erectile dysfunction and lower urinary tract symptoms. There is good evidence that tadalafil 5 milligrams once a day is as effective as alpha blockers, but obviously doesn't cause erectile dysfunction and can improve it. I put this slide in because I did a talk recently and I tried to find how I could reference the use for the 5 milligram once daily dose. It took me about 2 hours to find the right bit in the right publication from the Department of Health. Just to help you, I've put the boxes around it, and the long and the short of it is that if you've now got a patient who has low urinary tract symptoms and erectile dysfunction, you can prescribe this Cialis 5 milligrams without Schedule 2 or Schedule 11 because you're now allowed to prescribe that medication providing there's an alternative reason other than erectile dysfunction. Thanks very much.
Great. Well, thank you very much, Andrew. I'd like to thank all the speakers for excellent and well-timed talks. I've written down stop using stone expulsive treatment, be careful with active surveillance for Gleason's 7 patients, use more PDD, watch out for Urolift and mesh evaluations because we're still waiting for those. Can still do varicocele surgery but only give collagenase to private patients. Sildenafil is off the schedule, so that can be given to anyone. And I think, in fact, we're sort of running only 10 minutes late now. President Speakman, do you still want to start next session at 12:15?
Krishna Sethi is in the audience.
Is Krishna in the audience? No.
Let's stick with 12:15.
Fine. 12:15. So have a good coffee break. Thank you.